Hi, I'm Dr. Sally Weinstein, and I'm going to be speaking with you today about suicide risk and prevention in pediatric bipolar disorder, focusing on the important role of the family. These are my disclosures. The work that I'll be discussing in this video was funded by grants from the National Institute of Mental Health, as well as the American Foundation for Suicide Prevention. And I also received royalties from the sales of the manual for the treatment that I'll be describing today. During this video, I'll first present some background information on pediatric bipolar disorder, or PBD, and then briefly review the literature on what we know and what we do not know regarding suicide risk and treatment in PBD. I'll describe the treatment that we developed in our program at the University of Illinois at Chicago in the Pediatric Mood Disorders Clinic for pre-adolescents with bipolar disorder, called Child and Family Focused Cognitive Behavioral Therapy for pediatric bipolar disorder, and how we've applied this treatment for suicide prevention. And last, I'll present findings from our research trial examining suicide risk and response to this treatment in kids with bipolar disorder and their families. Pediatric bipolar disorder is a mood disorder involving episodes of mania and depression, and it's a diagnosis that is made in youth using nearly identical criteria as we use to make the diagnosis in adults. It involves periods of mania, which includes the experience of pretty extreme happy or irritable mood in the presence of other symptoms, such as increased goal-directed activity, increased talkativeness, a flight of ideas, or increased risky behaviors, along with a decreased need for sleep, among other symptoms. This is difficult to distinguish sometimes in kids because it's distinct from the typical exuberance of kids this age, usually a change in mood that doesn't really match the surroundings or the circumstances. And then there's periods of depression, which includes low, sad, or irritable mood with other symptoms, such as loss of pleasure in activities, changes in energy, sleep, and appetite. And this is really considered a spectrum with a diagnosis of type 1, 2, or not otherwise specified based on the severity and the duration of symptoms. Research has really highlighted that the experience of mood episodes is key to differentiating bipolar disorder from other mood spectrum disorders with overlapping features. And bipolar disorder that onsets in childhood has a unique presentation with developmentally specific symptom manifestations versus onsets in later adolescence or adulthood. Also, there's been some really great neuroimaging research over the years that has shown the differences in the structure and function of brain regions that correspond to the mood regulation difficulties that we see in children with bipolar disorder. And for this reason, we really consider this to be a brain disorder versus a behavioral disorder. Despite some controversy over the years, large epidemiological studies support that this is a reliable and a valid diagnosis in youth that affects approximately 1 to 2% of the pediatric population worldwide. We also know from research that children with bipolar disorder do not just experience these mood symptoms, but also experience impairment or difficulties across several life domains, including difficulties at the family level, with research indicating greater levels of family conflict and stress, difficulties with peers and social interactions, and difficulties at school, including neurocognitive problems, as well as lower rates of graduation from school. Within the child, we see reports of very low self-esteem and limited coping abilities. And not surprisingly, bipolar disorder carries the highest risk of suicide in all child psychiatric disorders. Suicide among youth in the United States is a significant public health concern and a leading cause of death in youth. As this graph shows, rates of death by suicide in youth now eclipse death by traffic accidents for children and adolescents. And among youth with bipolar disorder, these are an extremely high-risk group, with risk for and mortality from suicide exceeding that of any other child psychiatric disorder. Findings indicate that up to 50% of youth with bipolar disorder will make a suicide attempt by age 18. Even younger children with bipolar disorder experience high rates of thinking about suicide or suicidal ideation, with rates ranging from 25 to 55% in pediatric samples. Yet, despite these high rates, there's so much more to learn about factors that increase risk for suicide, specific to this group of youth with bipolar disorder. And even more is left to be learned about intervention and prevention. When we think about suicide prevention, we want to know what are the factors that relate to suicide risk in these youth specifically that we could be targeting in our treatments. And research in the literature has really highlighted family factors as key targets for treatment. Research on youth with bipolar disorder specifically has shown that family stress, conflict, and low family adaptability, which sort of captures the family's ability to change and adapt to different circumstances or stressors, are linked with increased risk for thoughts of suicide in youth. And conversely, in the depression literature, we see that family cohesion has been shown to be protective against suicide risk. In addition, parents' awareness and understanding of their child's mental health, as well as their ability to respond to their child and promote coping, significantly reduces risk of suicidal ideation in their offspring. So taken together, the research really highlights how family factors may influence suicide risk and, importantly, help with suicide prevention. However, how this translates into effective interventions for suicide risk in youth with bipolar disorder has not been well established. But we do have some promising research on suicide prevention interventions in youth overall. Several interventions have been identified in the literature as possibly or probably efficacious for youth suicide prevention. And I have the names of these treatments listed here, but I think what's most important to note is that these interventions really range across type, but all include a few common elements that have been identified as being really key for suicide prevention. And that's a focus on the family, a focus on building parenting skills, and a focus on child skills, particularly coping and problem solving. But even though we're starting to learn what works with youth in the broader youth population, we still have much to learn about the specific population of youth with bipolar disorder. And the question remains, what can be done about this important group? Few research studies have included youth with bipolar disorder, and so there's really a need for more understanding here. As a start, we can look to existing evidence-based treatments for children with bipolar disorder that may apply for the treatment of suicidality. One of the few evidence-based treatments for this population is child and family-focused cognitive behavioral therapy, CFF-CBT, or rainbow therapy, which was a treatment that was developed in our research program as an adjunct to medication for school-age children with bipolar disorder and their families. This treatment was not designed to address suicidality in these youth, but the core treatment components, which I'll discuss more in just a bit, include those effective elements for suicide prevention, a focus on family, parenting, and building child skills. And so the question is this treatment sufficient for suicide prevention in youth with bipolar disorder? And that's the question that we sought to answer. To address the gaps in understanding, the goals of our research have been first, looking at suicide risk to identify what are the child and the family risk factors for suicidal ideation that are specific to these younger kids with bipolar disorder that are modifiable and could potentially be targets for our treatment. And then second, looking at suicide prevention to explore if this treatment that we developed may reduce suicidal ideation versus a control treatment by targeting some of these factors. This work was conducted as part of a randomized clinical trial. This is sort of the research gold standard for examining new treatments or comparing different treatments. And this trial was examining the efficacy of CFF-CBT versus a treatment as usual control for pre-adolescents with bipolar disorder. We really focused on child and family risk factors along with symptoms of bipolar disorder and suicide risk at pre-treatment, at the end of treatment, and at a 6-month follow-up wave. The sample for this study included 71 youth ages 7 to 13 with a bipolar spectrum diagnosis that we recruited from our specialty mood disorders clinic in the UIC Department of Psychiatry. We established the diagnosis of bipolar disorder prior to starting treatment using a research measure interview. That's sort of the established way of making this diagnosis reliably. And we also looked at symptoms of bipolar disorder over time. For the work that I'm describing today, our main outcome that we were looking at was suicidal ideation, which we measured using a scale called the Columbia Suicide Severity Rating Scale, which asks kids about types of suicidal thoughts, ranging from passive thoughts of, I wish I was dead, to more non-specific active thoughts of, I want to kill myself, to more specific thoughts with method, plan, and intent. This measure also assesses the intensity of suicidal ideation, meaning how long it lasts, how frequent this ideation is, and how controllable it is for the youth. We looked at family and parent factors as possible key risk factors for suicidal ideation pre-treatment and mechanisms of improvement in ideation across treatment. And the factors that we looked at were first, a measure of family functioning. This has items asking parents and youth about the quality of life in their family's ability to adapt to changes and stressors in the family, and overall closeness. We also looked at family and parent problem solving, coping, and support seeking, as well as parent knowledge and self-efficacy about their child's mental health. For example, items might be, I feel confident in my ability to spot the early warning signs of difficulty in my child. And then we also looked at parents' own symptoms of depression. Beyond looking at these family and parent factors, we did look at some factors within the child as well, including the child's level of hopelessness, their self-esteem, and their problem-solving skills. And we chose all of these factors here based on what we've learned from the literature about what relates to suicide risk and prevention in youth. We also looked at age, sex, and severity of mood symptoms to see how these related to suicidality prior to treatment and over time. For the research trial, families were randomly assigned by coin toss to receive either the experimental treatment, which is CFF-CBT or Rainbow, which was a manualized, structured protocol or curriculum that was delivered by a trained study therapist in our specialty mood clinic. Those in treatment as usual received treatment that was similar to what would happen if a family went to the clinic and sought treatment for their child. So this was a non-manualized, non-structured therapy with a child and family therapist in our general child psychiatric clinic. So not someone who is necessarily specialized in pediatric bipolar disorder and someone who is not familiar with this specific Rainbow protocol, but a child and family therapist. And all youth and families received 12 weekly sessions and 6 monthly maintenance sessions, as well as medications that were prescribed and tracked in our specialty mood disorder clinic. And these youth and their families were assessed and asked many of these questions at baseline or prior to treatment, at post-treatment, and a 6-month follow-up by a clinician rater who did not know which condition they were receiving or blinded to condition. Before discussing what we've learned from this research, I wanted to walk you through the treatment that we are delivering to the child and family to really give a sense of how this treatment may apply for suicide prevention. So as the name implies, the treatment is cognitive behavioral in focus, but also incorporates psychoeducation and elements of mindfulness and interpersonal approaches to really meet the range of needs that youth and families present with. This treatment was developed to be an add-on to medication for school-age children and their families, and as I mentioned before, was not designed to address suicidality. But as you'll hear in a bit, the core treatment components included those elements identified as effective for suicide prevention in the literature. And the treatment content was really informed by what we've learned from research on pediatric bipolar disorder and the unique needs of this population, including first, the unique symptom characteristics that we see in young youth with this early onset bipolar disorder. These are things like frequent cycling or rapid cycling between mood states, the prominence of rage and irritability, and also high levels of comorbidity or co-occurring psychiatric disorders. Second, the content was really informed by findings from neuroscience research that's looked at the brain and has told us more about the affective circuitry dysfunction that really seems to underlie the mood difficulties that we see in youth with bipolar disorder. And last, the research that has documented the impact that, or the toll that bipolar disorder takes on functioning at the peer, family, and school domains. And this all comes together in the 7 core ingredients of our treatment model, which form the acronym RAINBOW. And each component was developed to target these 3 key areas of research that I described. And to give a sense of how this treatment is relevant for suicide prevention, I'll briefly hit the highlights of each of these components. Starting with the R of RAINBOW, which stands for routine. We know that youth with bipolar disorder experience mood dysregulation, and we also know that disruptions in routine or a lack of structure can trigger and intensify mood difficulties. So goal of this component is to improve mood regulation and decrease symptom exacerbation through establishing consistent daily routines for the child and family. This worksheet is an example of what we use in our treatment. We identify what are the most difficult time periods or transition periods in the family, bedtime, morning time, transitioning from home to school, and develop consistent, predictable, and soothing routines to help ease the difficulties at each of those time periods. The second component focuses on affect regulation, grounded in what we know about brain function in bipolar disorder and how this relates to difficulties with mood regulation. In particular, that youth with bipolar disorder experience overactivation in the emotional centers of the brain, or the limbic system, in concert with decreased activity in the prefrontal cortex, or the thinking center of the brain, in response to negative stimuli. So this happens in response to being told no, having to stop doing something fun, or getting in trouble in school or at home. And it causes a flood of negative emotion here in this emotion center without the tools in the thinking center to really rein this in. And so the goal here then is to develop behavioral management skills for the parent and coping strategies for the child to compensate for these difficulties at the brain level and to really strengthen this brain circuitry. Young brains are plastic and still developing, and the more skills that we build at this early age, the more these circuits can be strengthened. And here are some of the materials that we use in this component to increase identification and expression of feelings with this feelings poster, to recognize the warning signs of anger and other difficult feelings in the body, maybe before our brains register that we're feeling angry. We identify the triggers of mood difficulties, which we call bugs. And we also identify cognitive and behavioral skills. We call them think and do skills, mind, body, and behavior skills that we can use to really manage these triggers. And here's a great example of one coping strategy developed by one of our families. This child created a cool down corner in her room with a list of coping strategies, soothing images, and soothing toys that she would go to and use to help cope with intense affect. I stands for I can do it. And research suggests that self-efficacy, a sense that you know what to do and you can do it effectively, plays an important role for youth and for families for managing mood episodes. And we also know that youth with bipolar disorder often experience very low sense of self. So the goal of this component is to increase the family's belief in their ability to cope with the disorder, and also to improve self-concept by promoting the child's strengths and increasing positive self-talk for the child and for the parents. We do this with parents by focusing on how to recognize, highlight, and strengthen their child's competencies, how we can find opportunities for success and mastery experiences, and how to give consistent positive reinforcement and pep talks, even for small things. And last, how the parent can develop their own positive coping and mantras about their ability to cope. N stands for no negative thoughts and live in the now. And the goals of this component are twofold. The first is to decrease negative thinking patterns in both the child and the parents. And the second goal draws on mindfulness to encourage a focus on coping in the moment to avoid becoming overwhelmed by thoughts of the future. B is again a two-part component. As I discussed, children with bipolar disorder often have significant social difficulties. And so the first goal here is to improve social functioning in children and to build those core social skills. But parents often experience their own stress and strain. And so a second goal is to enhance parental self-care and balance in their life. With parents, one activity that we do is called recarving the pie. It's an activity to identify how they're currently allocating their time and then to redistribute this time to improve balance and self-care. O addresses problem solving and communication skills with the family. As the literature suggests that these skills can be impaired, and families tend to experience high levels of stress and conflict. So an example of one activity that we would do here is developing and practicing the use of I messages, or a positive communication strategy that kids and parents can use together. We also work with the entire family to develop a plan for coping with specific triggers or bugs within the family, as well as with the child's intense mood episodes, identifying coping skills that each family member can use, how and when to use them, but also ways to celebrate their success when these skills are used. And finally, treatment focuses on ways to seek and increase support systems in the family, the school, and the community, as stigma, isolation, shame, or a lack of access may prevent families from finding or using support networks. And here we develop support trees as great visual reminders of those in their support networks. Here's just a breakdown of how these 7 different rainbow ingredients are sprinkled across the 12 treatment sessions in the manual and who is involved in each of these sessions. So now, knowing some of what we are actually doing in this treatment, I want to shift the focus to the research that we've conducted, examining if and how this treatment works for youth with bipolar disorder, and most importantly, how this can relate to suicide prevention. The first area of work, we wanted to know, before even starting the treatment, what are the child, the parent, and the family risk factors for suicidal ideation in youth with bipolar disorder that we could be targeting in our treatments. We looked at this question in our sample of 71 youth with a mean or average age of 9 years, so a pretty young sample that was fairly diverse in terms of the racial ethnic composition as well as socioeconomic status, with moderate illness severity. So this was a young sample with a complex clinical presentation, pretty representative of the population of youth this age with bipolar disorder. We first wanted to know, what are the rates of suicidal ideation in these young kids? This pie chart shows lifetime rates of the most severe type of suicidal thoughts that the youth has reported experiencing in the past. 39% of the sample reported no thoughts of suicide ever in their lifetimes, which means that almost 2/3 of the sample reported a history of lifetime thoughts of suicide, ranging from passive thoughts to more severe thoughts with plan and intent. And I just want you to keep in mind, these kids are 9 years old. Findings from the Centers of Disease Control and Prevention in 2017 indicated that the past year prevalence of suicidal thoughts in 18 to 25-year-olds, much higher sample, was 10.5%. So I think these findings really suggest that suicidal ideation seems to be the rule rather than the exception in these young kids. Looking at our main outcome was current thoughts of suicide, which we defined as any thought of suicide in the past month. When we're looking at just past month ideation, the rates are slightly lower. 60% of the sample had no experience of ideation in the past month, but that means that still 40% of the sample was reporting suicidal ideation in the past month, ranging again from passive to more severe thoughts with intent or plan. So our first question was, what are those risk factors that differentiate youth with and without any suicidal ideation? And we looked at kids with any ideation in the past month, as well as a subgroup of kids that were experiencing more severe forms of ideation, which we called planful ideation, which meant active thoughts of wanting to kill themselves with method, with or without intent. This table is complicated. It displays a statistic called the odds ratio for these child and family factors that we were exploring, which helps us understand how the risk factor relates to suicide risk. What are the odds of the youth having any current ideation pre-treatment? And what are the odds of the youth having this more severe or planful ideation if this risk factor is high? When we examined all these different factors together, we saw that a few remained significant and stood out to increase the odds for more planful ideation, including child self-esteem. The lower the child self-esteem was, the higher that risk was, as well as family rigidity, which is sort of the opposite of family adaptability, that this increased the odds or the risk of more severe suicidal ideation in youth, and thus highlights child self-esteem and this family factor as important factors to target in our treatments. And that brings us to the second question. Does the treatment I described, even though it was not designed to focus on suicidality, reduce suicide ideation in youth with bipolar disorder versus our control treatment as usual? Before we could get to that question, we first want to put these findings in context of our primary symptom outcomes in the trial. We saw that our treatment outperformed the control treatment in terms of symptoms of mania, which you can see in this graph here. You see for those in CFF-CBT, the mania symptoms are reducing over time, whereas for those in the control treatment, they're kind of fluctuating above that clinical threshold. And also for symptoms of depression, again, those in CFF-CBT in the green, we see that reduction, whereas those in the treatment as usual were kind of fluctuating. Now looking specifically at the suicide ideation outcomes, these graphs display first the number or prevalence of youth endorsing current ideation across treatment, as well as ideation intensity scores across treatment for those in CFF-CBT in the green compared to the control treatment in the blue. The findings here were pretty interesting. We saw that all youth improved over time, which was really promising. And for youth in CFF-CBT or Rainbow, we saw that there were fewer youth reporting ideation by follow-up and a steeper change in this ideation intensity across treatment. But these differences by treatment condition were not statistically significant. Even though we can see some of these changes, this did not register as statistically significant, which begs the question, is this too small of a sample to detect a signal here? Or are both treatments sufficient for suicide prevention at this early stage of severity? And finally, we saw that across both treatments, kids were improving in their ideation. And so that leads to the question of how or what? What are the family and child factors that we're changing in our treatments that are contributing to the reduction and improvement in suicidal ideation? To answer this question, given that we did not see differences for youth in Rainbow versus the treatment as usual condition, we explored these factors across all youth, across both treatment conditions. And what we found was that at the family level, that improvement in family coping across treatment predicted a reduction in suicidal ideation by the end of treatment. And the same was true for family functioning or quality of life within the family. At the child level, we saw that our other risk factor for ideation that we saw pre-treatment, which was child self-esteem, that improvement in the youth's self-esteem across treatment was responsible for some improvement or reduction in suicidal ideation across treatment. These findings have some pretty important implications for our treatments and really for the importance of focusing on the family system as well as child self-esteem. Interestingly, we saw that changes in youth coping skills were not responsible for the improvement in suicidal ideation across treatment, which suggests that in these younger kids, this coping is really happening at the parent and family level. That's where the action is until these youth's brains mature and allow for more sophisticated coping skills. So the take home across all of this work is that, first of all, suicidality is quite prevalent, even in this young sample, which is certainly consistent with what we've learned from the literature on risk for suicide and bipolar disorder. And these findings really speak to the importance of assessing and addressing suicide risk in this population, and doing this early on in the continuum of severity. That is, while these kids are still thinking about suicide, but not necessarily yet acting on their thoughts. Research suggests that among these younger kids who are experiencing suicidal thoughts, that the highest risk for making an attempt, for transitioning from thinking about suicide to acting on those thoughts, occurs in that very first year following the onset of this ideation, suggesting that this is a really key window for intervention and prevention, while these youth are still thinking, but not yet acting. Second, we saw that youth with planful ideation, that more severe form of suicidal ideation prior to treatment, reported lower self-esteem and came from families with greater rigidity or less ability to adapt to changing circumstances and stressors, suggesting these as really important targets for our interventions. We also saw that our treatment, CFF-CBT or Rainbow, although not designed to address suicidality, may hold promise for youth suicide prevention and reduction in youth suicidal ideation. And this treatment does target those identified risk factors for ideation and those common effective elements for suicide prevention in youth, the focus on family, parenting, and child skills, and may generalize to suicide prevention as a result. Yet, we saw that youth also improved in our control treatment. And it may be that we're intervening early enough to prevent progression in suicidal behavior, even in a treatment that's not specialized for bipolar disorder. The treatment as usual was a family-based with high satisfaction ratings from families, and notably had much better attendance than a typical control treatment, and may have been sufficient for suicide prevention. And last, when we looked at possible mediators of these treatment outcomes, when we were looking at what are the factors that are responsible for these changes that we're seeing in suicidal ideation, we saw that improvement in those family and child risk factors for ideation prior to treatment did correspond in the reduction in ideation across treatment. That is family functioning, family coping, family rigidity, and child self-esteem, further underscoring these targets as being important for our intervention. But ideation was not entirely eradicated in either treatment, and actually crept up a bit from post-treatment to the follow-up wave, suggesting that it may be necessary to directly target ideation in our treatments and really expand our focus on these identified family risk factors to optimize our treatments for suicide prevention. So how can we do that in our treatments? And more importantly, how can we translate these findings into what families can do at home? Well, first, communication is key, but talking openly about suicide thoughts and risk is a first and important prevention tool. We know from research that asking about suicide risk does not increase risk. Rather, it often decreases distress and also sends the message to youth that this is a safe space. But it can be really hard for youth to talk about this, which may decrease their willingness to share. So it can be very helpful to come up with a code word or ways to talk about different risk levels of intensity to talk about the intensity of these thoughts. I like using a color system where yellow may mean I'm having these thoughts, but I can control them and I can use my coping skills, but I'm alerting you that I'm feeling unsafe. Orange meaning I'm having thoughts and I'm having some level of desire to act. And red meaning I'm not feeling safe anymore and I need urgent help. And that would signal the need to get more intensive treatment, calling 911 or going to the emergency room. As hard and emotional as this can be for caregivers, it really helps to stay neutral, open, and accepting during these discussions. It's important to communicate that the child's not in trouble for these thoughts. We want to reinforce honesty and reinforce that the child is advocating for their own safety and needs. Second, our findings suggest that building family coping and family problem-solving skills are really important protective factors. At these younger ages, the child's skills were less important and was more important what was happening in terms of the family coping. And the way that we can do that is by proactively and collaboratively thinking about stressors or triggers as a family in advance and how the family can work as a team to cope and to stay safe. Also, talking about ways that parents and family can help the child use their skills, how the parent can help provide distraction, provide support, or do coping activities together to strengthen those skills in the child, but also knowing when and where to seek professional help. And last, a big takeaway from our work was that family quality of life was really protective. And this can be enhanced by prioritizing one-on-one parent-child time, where the child is in the lead, gets to make the decisions and call the shots about what the family is doing together. And also engaging in positive activities as a family. This sounds simple, but really often gets lost in the hectic day-to-day of our lives, and so important to plan ahead and put on the calendar. But families are not in this all on their own. As helpful as some of these strategies that I mentioned can be, there are great resources and support available. And I put a few up and encourage you to check them out. And with that, I want to thank you for your time and attention, thank our funding sources, and also thank the research team and all of the families that made this work possible and help us begin to understand what we can do to better help kids with bipolar disorder and their families deal with some of these really tough emotions and situations. Thank you.